Welcome everyone to another short presentation on the Insights World Tour. We are in Canada today with a colleague and collaborator and friend, but let me just remind you all first what the Insights World Tour is. My name is Mo Bindari, Editor-in-Chief of Ortho Evidence, and these are by design small group sessions that to really hopefully facilitate more interactive discussion. So we'll have a short presentation followed by, we believe, 15, maybe 20 minutes of discussion on a topic of interest, of high interest to the orthopedic community. If I could, and I think it seems like most people here are doing that, if you can just stay muted and off video during the presentation period, that'd be wonderful. We'll obviously ask you to come back on video in about 15 minutes or so. We'll be able to have a more direct and interactive discussion. I also urge you, if you can, just to take a moment to take a look at what's coming up later this evening, as well as tomorrow. We still have some presentations as part of this 4-day, 15 event world tour of sorts. So if there is something you want to see as well, we encourage you to go to oeworldtour.com and take a look. Now, without further ado, today we are going to, and this evening, we're going to be spending a little bit of time with a colleague, Dr. Jason Bussa, who's an associate professor and associate director of the Michael DeGroote Center for Medicinal Cannabis Research, as well as working at HEI at McMaster University. He's going to be talking about a program of research that he's been involved in for several years that's focusing primarily on persistent pain and post-surgical pain after fracture repair. Jason, thank you so much for spending a bit of time with us and welcome to the OE Insights World Tour.
Thank you very much. And I'm going to apologize a little in advance. There's a small disconnect between my title and my presentation. So I think we sent around a couple of different topics and we ended up landing on a recent review of management of acute musculoskeletal pain. So I apologize for that. But
we're good, yeah.
The topic today is really looking at management of these musculoskeletal injuries, and we conducted something called a network meta-analysis, which I'm going to talk briefly about today. First, disclosures: the work was funded from a grant from the National Safety Council, and our findings did inform a clinical practice guideline from the American College of Physicians and the American Academy of Family Physicians. In terms of very brief background, there are lots of treatment options for managing acute musculoskeletal pain. However, patient outcomes are often not optimal. To give a sense of what I mean by that, in 2007, there was a North American survey of 842 patients that presented with acute pain for outpatient care. However, after visiting the emergency department, 40% reported unchanged or increased pain, and 74% were discharged with moderate to severe pain. So a lot of variable care out there, and obviously there could be room for optimizing the patient experience. So what we did is we undertook a systematic review and network meta-analysis of randomized clinical trials assessing treatment for acute pain from non-low back musculoskeletal injuries. Why did we avoid low back? That topic was covered in a previous guideline published by the American College of Physicians in 2017. And our review was published about 6 weeks ago now in the Annals of Internal Medicine. So what is a network meta-analysis? Where the reality is that most trials of treatment for acute pain compare an intervention versus a placebo. And this is not really what we want to try to understand when we're deliberating between competing interventions. A network meta-analysis will take advantage of any head-to-head comparisons or direct comparisons that we may have, but it also allows us to create those head-to-head comparisons. If I have, for example, NSAIDs versus placebo, I have another group of studies of opioids versus placebo. By the fact that they have a similar comparator, I can create a head-to-head comparison if that trial had been done. And this is called indirect evidence. And we use a combination of both the direct evidence and the indirect evidence for creating the network estimates. This is a simple flow diagram, and we had very broad criteria. Any trial looking at adults presenting for outpatient management of pain due to an acute musculoskeletal injury. And you can see we had 207 trials that were eligible, and 154 of those were suitable for meta-analysis. We worked with a technical expert committee that was part of the guideline to choose outcomes of interest before we undertook the review. You can see them listed here. We had 8 outcomes. Many of these were beneficial ones, looking at pain, physical function, quality of life, patient satisfaction, return to work, proportion of patients with relief, re-injury, and adverse events. We did have to choose time points. Now, acute pain, by its very nature, is self-limiting. It will resolve. So for most of the outcomes, we looked at the longest time point reported, but not for pain. For pain, we looked at the most commonly reported time points, and that ended up being pain at 2 hours or less, pain at 1 to 7 days after treatment, and then longer time periods beyond a week. So those were the 3 time points that we looked at for pain. The other outcomes, we looked at the longest time point reported. And I've mentioned a very broad category here, adverse events. What we did for that is we looked at all the adverse events that had been reported in the clinical trials, and we grouped them with help from our technical expert committee into categories of complaints, into gastrointestinal adverse events, dermatologic adverse events, and neurologic adverse events. And we had to prepare our data for analysis. And the first step was clustering similar interventions. First, we only considered currently available treatments. And again, we relied on our clinical experts to help us in that regard. And we largely grouped according to intervention class, such as considering all non-steroidal anti-inflammatory drugs together, unless our clinical experts advised against it, or if we found either different effects or heterogeneity by doing so. And what I mean by different effects is when we disaggregated all of our interventions into their individual ones, the network meta-analysis allowed us to compare the effectiveness of individual NSAIDs, for example, against each other. If they're all acting in a similar manner, we wouldn't expect to see any significant differences. So that's something that we look for to give us greater confidence that we could aggregate treatments together. We did have some notable exceptions, one being NSAIDs. We had a number of trials that looked at oral NSAIDs and a number that looked at topical. Our experts said these were going to be different. Our statistical analysis suggested important differences in terms of adverse events. And so we did break oral and topical NSAIDs into separate nodes. Also opioids. We found that tramadol, which is a prodrug, did respond differently or did produce different effects than other opioids plus acetaminophen, and that fentanyl, when administered as in a transbuccal manner, also looked as if it was behaving quite differently. So opioids was disaggregated into 3 nodes instead of keeping it as 1. We also had to make an important decision. Can we combine treatment effects across all acute musculoskeletal injuries? And we talked about this with our technical expert panel. And what they told us is whether we're looking at an ankle sprain or a shoulder sprain, the process of healing was largely consistent across these kinds of injuries. Therefore, they postulated the effect of different treatment interventions was likely to be similar. We looked at this issue statistically, and we did not find a great deal of heterogeneity by combining across these conditions. And also, and maybe most importantly, about half of all the clinical trials that we looked at enrolled mixed patient populations. So the trialists that were running these studies made no distinction whether patients were coming in with a strain or a sprain or a serious contusion or a fracture that was managed non-operatively. They combined these patients together and they reported the results across all their patients, not broken down by the specific type of injury. So all these factors gave us confidence that we could indeed do our analysis across all these clinical conditions that were all acute pain complaints. We built what's called a network map for each of our outcome measures. This is the one here for pain at 2 hours or less post-treatment. And you can see here each of these treatment nodes. This is the one for oral NSAIDs. they're different sizes. And the larger nodes represent more patients contributing to that node. You also see that the dark line showing the direct comparisons and the thicker lines mean you have larger number of trials. You see most of the interventions connected to placebo, but not in all cases. Acetaminophen, for example, we couldn't find any trials that directly compared against placebo, but we do have acetaminophen versus oral NSAIDs and oral NSAIDs versus placebo, so we can create the indirect evidence for acetaminophen versus placebo. Now, how do we calculate the network estimates? This is a busy table. I don't expect you to look at it in any great detail, but I showed you before that acetaminophen versus placebo did not have any direct evidence, and so we didn't have any to work with. We were able to calculate indirect evidence, and this then becomes the network. In other cases, such as acetaminophen and opioid versus placebo, we do have direct head-to-head comparisons of that. We also have indirect. We combine these two to come up with the network estimate. And we rate all of these according to the certainty of evidence using something called the grade approach. So what I want to convey from this is that we do take advantage of all the direct evidence, but we also use the indirect evidence in every case. And because of this, the indirect evidence is quite important. And it's very reasonable to ask, can we trust these created head-to-head trials? Can we believe the indirect evidence? There was a very well done paper published about 10 years ago now in the British Medical Journal that explored this exact issue. They looked at the concordance between indirect evidence and then head-to-head trials that were subsequently done. And they found a high degree of concordance, but not perfect. They were concordant about 86% of the time. So this means often the indirect will be reliable, but you have to check to be sure. And you have to look at the level of the network and the level of the individual comparisons. One way we look at the level of the individual comparisons is by putting together something called an incoherence plot. And really what we look for here is that the lower level of the confidence interval for the incoherence factor does hit 0. And if it does that, then statistically it tells us there is no problematic disconnect between the direct and the indirect evidence, and we can have a high degree of certainty in combining them to come up with the overall network estimate. Now, what if we had seen inconsistency? Well, we looked at hundreds of comparisons for our analyses. We did find 2 cases in which there was inconsistency. Now, in one case, both the direct and the indirect evidence had similar quality of evidence. So we don't know which one to believe. In that case, we took the network estimate, but we downgraded the certainty of evidence 1 level for inconsistency. In the other case, we had moderate quality evidence for the direct and only low quality evidence for the indirect. In that case, we believed the direct more. So we took the direct instead of the network estimate. So what I'm trying to convey is there's a lot of work that goes into these kinds of analyses to try to give greater confidence in the ultimate findings. Now, how do we present these results? How do we look at the comparative effectiveness of multiple competing interventions? If you read these network meta-analyses, you will typically see the results ranked according to what's called the SUCRA method, surface area under the cumulative ranking curve method, or surface under the cumulative ranking curve method. And it comes up with a number of plots. Now, this is for the outcome of treatment satisfaction or patient satisfaction with treatment. And to explain it here, this is the probability. So 0%, 20, 40, 60, 80, 100%. And this is the ranking. So what you can see is that there is a 0% chance that placebo is the best therapy. 0 that it's second or third or fourth. There's a 100% chance that it is one of the worst interventions out there, which makes a lot of sense. You see education showing a similar type curve, right? Very, very low probability that it is amongst the most effective, high probability that it is amongst the least effective. But what do we see when we look at all these curves? Well, joint manipulation seems to be the best treatment. Low-level laser therapy is number 2. right? We can see manipulation comes up very high very quickly and stays there. Laser therapy does something similar. Do you believe it? Do you believe that when looking at across all these interventions, these two are likely to be the best? And I hope the answer is you are skeptical of this, and you would be right to do so. The problem with the Sucre method is it only looks at the point estimate of effect. It fails to consider the precision around the estimate, and it fails to consider the quality of the evidence. So we took a very different approach to ranking competing therapies. And you don't have to read anything else in our paper if you understand this one table. This is it. What we've done here is we have colored in light green interventions for which we have moderate or high certainty evidence that they are better than placebo for an effectiveness outcome. If they're in dark green, then they're not only better than placebo, they are better than at least one other competing intervention that is more effective than placebo. So you really want to see the dark greens. That tells you you've got really effective therapies. What if you see a clear cell? There we have moderate to high certainty evidence that it is no better than placebo. And if you see a gray, it simply means we only have low or very low certainty evidence. So we put the grays in to not draw your attention very much to these interventions. We simply don't have good enough evidence to be confident in those treatment results. Now for harms, we simply used light red and dark red coloring, but it's the same thing. If you see a light red, then the intervention is more harmful than placebo. If you see a dark red, the intervention is not only more harmful than placebo, it's also more harmful than something else that's more harmful than placebo. So dark red amongst the most harmful, light red is harmful. If it's clear, no more harmful than placebo. And once again, if you see the grays, we do have evidence, but that evidence is only low to very low certainty. And then we rank all these interventions. And what we want to see is the net benefit go from most favorable to least favorable. So what you would expect to see if we've done this correctly is a lot of dark greens up here and not much red. And down here, a lot of clears and a lot of dark reds. And what I should also state is if you see just a dash, we didn't have any evidence to inform that intervention for that given outcome. So when we look at this, I hope that it becomes clear that the interventions that seem to show the most promise were probably these 4 or 5 up here. These are the ones where we have at least moderate certainty evidence. We do see strong evidence of effect, and we don't see much evidence of harm. Whereas down here, we either do not have evidence or we see good evidence that they're ineffective, and we see lots of evidence of harms. So in conclusion, looking at the totality of all this, I should highlight, here is the symptom relief or the the symptom relief for joint manipulation. Again, you see a massive odds ratio suggesting a huge effect, an odds ratio of 167, but it's only informed by low certainty evidence. And look how imprecise it is. It goes anywhere from 6 up to 4,200, right? The problem with the Sucre is it only looks at this number. It doesn't look at the imprecision or the certainty. I think that's why this method has a lot more promise for accurately conveying relative effectiveness with network meta-analyses. So in conclusion, we found moderate to high certainty evidence that topical NSAIDs followed by oral NSAIDs, acetaminophen and acetaminophen plus diclofenac, showed the most attractive benefit to harm ratio for managing pain secondary to these acute musculoskeletal complaints, and our results demonstrating that opioids fail to achieve important benefits beyond interventions with less harm, such as the 4 listed above, provide compelling reasons to avoid opioid prescribing in the setting of acute non-low back musculoskeletal injury. And with that, I'm happy to take any questions.
Superb, Jason. Thanks so much. Why don't we have those of you who are on maybe just come on video if you can, if you don't mind. That way we'll know who we're talking to, and we'll go from there. I also see, I think someone is wanting to make a comment. So I'll open it up to you, Yaping, to speak.
Hi, I'm Yaping from Also Evidence. Jason, thank you very much for your great presentation. I have one question. Because your studies to help ACP to develop a guideline, and I'm assuming you have presented the results to them several times. And during that process, what were some of the challenges to communicate the findings to them? Because network meta-analysis is relatively complicated. And how did you resolve those challenges or something like that? Thank you.
Yeah, so hi, Yuping, nice to see you again. It's an excellent question. And when we were first approached by the ACP, they had envisioned more of a narrative review. That's how they had typically informed their prior guidelines. And so that's what they were more used to. And we first had to sell them on the concept of a network meta-analysis, and then we had to really go through in detail about what it meant. So it was an extensive but a critical aspect to what we did. We had a lot of meetings before we embarked on the analysis to explain why we were doing, the steps we were taking, what it would mean. We worked very closely with their technical expert committee to really make sure that they understood each step of the process. We had an interim presentation partway through. We had a final presentation. We had lots of back and forth after that. Many questions came from the panel that we addressed and provide clarification to. And I think one of the most helpful things we did was the presentation of that one table that I put up, which was, it really resonated with the panel members, much more so than putting up a lot of the complex, analyses or the network plots or, a lot of the other things that we tend to use that we bury in an appendix with these. So we're very hopeful that that table is going to provide a very straightforward way of conveying the results. And we have one of Mo's PhD students, Mark Phillips, is actually involved in doing formal user testing of this presentation and in different ways. And the preliminary results look very promising. So it's a great point. These network meta-analyses are quite complicated, and it is incumbent on researchers getting involved in this methodology to find a way to present the results in such a way that they are approachable and they do help clinicians and patients to make decisions.
Jason, let me just walk this back a little bit, because you and I both remember, well, at least I do anyway, 20, 25 years ago when the term meta-analysis was becoming popularized. And, we saw it in medicine and in orthopedics, let's say, to relevant, specifically to the ortho evidence population. We started seeing, things start moving up, and around 2005, it just exponentially went up. And it went up because software suddenly became available, and you didn't have to necessarily be a scientist to conduct meta-analysis. In fact, you almost needed very little research training to conduct it, and it's continued onward. When do you recall in your own trajectory of thinking about where meta-analysis fits in, and it was always about, garbage in, garbage out, and the quality of meta-analysis and the scientific methodology. When do you recall your transitioning towards network meta-analysis, and where do you think we are in that trajectory? As far as we've come with meta-analysis, where are we relatively in that timeline as it relates to network meta-analysis?
It's a great point, and I think what you have to be worried about with whether it's a conventional or a network meta-analysis, yes, you're right, garbage in, garbage out. You cannot create good data from poor primary studies. The other thing you mentioned that I think is critical is the ready availability of software to do this. When I look at where I'm at with network meta-analysis, I am still learning. There's a lot to be developed in this approach. As I said, if you look at so many of the network meta-analyses, they will very quickly present one of these sucra rankings. They will say this treatment is number one, this number two. It's very appealing, this idea that you can very quickly rank your interventions. But I hope from what I've shown you is it also has a massive potential to mislead. With the increasing availability of software to do these network meta-analyses and with the complexity towards understanding them, which Yuping highlighted, I think there's a real danger of a lot of very low quality network meta-analyses being put out there, potentially being quite influential and possibly misguiding decisions out there. So this is not an area that is as well developed as conventional meta-analyses. There is a lot of work unfolding, both in how to properly do it and how to interpret the results and how to present the results. And so I do think it's a bit of a wild west at present, and there's probably a lot of reason to be cautious when you read one of these reviews before taking the results at face value. And again, to highlight, I am still learning quite a bit. I'm involved in a lot of these right now. We're trying to make each one we do a little bit better, and really trying to go back to the sort of end users of these, as we're doing with the project Mark Phillips is leading now. Say, what do you take away from this? How can we convey this so that your interpretation is likely to be highly concordant with the evidence that we've presented?
So when we think about the hierarchy of evidence, and so for most here who are joined us this evening, and more so for those when we put it out to the larger 70 some odd thousand members we have, when this is recorded and put out, the hierarchy still has randomized clinical trials at the top. Where does the network meta-analysis fit in, do you think, or where do you think it will ultimately find its place in the hierarchy of evidence for treatment?
Yeah, I mean, when you talk about evidence-based medicine, or more broadly evidence-based clinical practice, there's sort of those three pillars. There's and one of which is there is a hierarchy to the evidence. We have to consider all relevant evidence, and evidence alone is never enough, right? You need patient values and preferences. You need clinical expertise. When it comes to considering all of the available evidence, network meta-analysis has a leg up on conventional systematic reviews and meta-analyses because of its use of the indirect evidence as well as the direct. So I do think it has the potential to really take a place quite high up that hierarchy. But again, if I had a network meta-analyses of 20 small trials and you showed me a huge, well-done, randomized control trial, I would be hard pressed to take the results of that network over that single large, well-done clinical trial. I think what we're going to start to see more and more, though, is the idea of a living systematic review. And you're starting to see this come out in the area of COVID, for example, where the information is coming so fast and so furious that we want to see these reviews incorporate the latest information into their estimates so that we don't have to wait a year or even 6 months, but every month or two with this sort of rush of new data, it's being incorporated, and then you're getting the best overall estimate. So I think the potential is there for network meta-analyses to take a very important role and a very high place in that hierarchy of evidence. But again, it has to be done well. And ideally, it's going to take on more and more features of this living systematic review, where it's always changing based on the latest and best information from good primary trials.
So I'll feel free, anyone else has a question, and I know we've diverted into the methodology of the tool that was used to talk about sort of chronic non-cancer pain as part of the overall story. But were you particularly surprised, Jason, that NSAIDs are the only thing that seem to work for pain? And I guess, and if that's the case, there's 20 different treatments out there, or more than that, there were a lot more than that. What does that mean? Does that, if we believe this, right, and you provide some compelling reason we should consider it, what does that mean for all the other treatments for pain at this point? What does that mean? Should we be really seriously reconsidering? Should we be calling for more head-to-head trials to see if we can confirm the indirect evidence you have? Because pain is, billions and billions and billions of dollars of cost, and also revenue for various treatments. So how do we reconcile this?
Yeah, I think we have to be realistic about the evidence underlying some of the other therapies that are out there. So we did find, for example, this transcutaneous electrical stimulation, these TENS machines.
Right.
Preliminary results look very promising. It may be equally as effective to NSAIDs, but right now the certainty of evidence is low. We don't have enough evidence to say that with certainty. So I think we should call for evidence in areas where there appears to be promise, but we don't have enough certainty to be confident in that yet, to expand the sort of realm of interventions that are available. There were a number of non-pharmacologic interventions that look promising. I think we also have to take a very careful look at areas where there's high use of certain products, but the evidence is not supporting it. And we highlighted opioids as sort of a prime example. There's been recent epidemiologic studies done in the US and looking at uncomplicated type 2 ankle sprains, for example, finding that 25% of those patients leave a clinical encounter with a prescription for opioids. That's a lot of people receiving opioids. And if we do have good evidence now, which I believe we do, that either NSAIDs or acetaminophen will demonstrate an equal effect, but without the risk of neurologic and gastrointestinal harms at the level that opioids can be associated with. And that's not even talking about some of the more rare but potentially catastrophic harms that can occur. I think that gives us reason to move some therapeutic options out of the clinical algorithm, prioritize ones where we do have better evidence, especially for that sort of net benefit to harm ratio. And then, as you said, for a lot of those interventions you saw in the middle of that table with a lot of the gray cells saying, maybe, but we're not sure, let's encourage more research in those spaces from people that have a particular interest in trying to explore that, in particular with some of those non-pharmacologic options, to see if they are realistic, if they are appropriate for consideration as well.
That's very good. I want to make sure if anyone has a question or a comment you'd like to make. We are nearing the end of the 30 minutes. We maybe have just hit that mark now. So I want to make sure if anyone has a question, please do unmute and let us know. And if not, I'll ask one final question to you, Jason, and also give you a chance to maybe give us a final closing comment. I was struck by, and the first thing I would have said, right, in a network meta-analysis where you're doing indirect comparisons, the biggest issue is comparing it to head-to-heads to say, okay, if we're using this approach, the trials haven't been done in the past, but we're going to see if they were done, what could they have shown? And that 86% concordance is very helpful. Was there any sort of mention made around the 14% though that were discordant? Can we learn from the times that it didn't work to say, okay, these were the features that led to discordance, so therefore when you're in that situation you can be less likely, or you could downgrade that evidence somehow?
Yeah, no, you're exactly right. So what that paper really highlighted was we cannot assume that the indirect and the direct are going to give us the same message every time. About 86% of the time they do. And so that gives us some confidence that it's more likely than not. But in the way that they sort of were able to explore for those differences was often by doing formal statistical tests. I mean, I showed you those incoherent plots, for example.
Yeah.
So it's important to not only make the assumption, but then to formally do the statistical tests, to look to see whether you really are getting systematic differences between those two. And if you are, then you have to think very carefully if you can believe the network. And so again, we had hundreds of comparisons. We found that signs of incoherence in 2. We alerted the technical expert panel for the guideline right away. We said, be careful. There's signs here that we can't simply believe that the indirect is going to be accurate. And then, as I said, in the one case where we had higher certainty of evidence in the direct, the panel said, and we agreed, well, we're going to take the direct because those are the head-to-head trials, and it's higher certainty. Yeah. So even though we get, improved precision by including all the indirect as well, we don't believe it. And so we're not going to simply add it in. And in the one case where we had similar quality of evidence for the direct and indirect, but they were giving us some different messaging, we said, we don't know which one to believe here. We are going to take the network, but we're going to downgrade it because of this problem with inconsistency. And we're going to highlight this as an issue. And obviously we'd like to see more research done in that space so we can try to resolve that at some point.
Well, before I let you go to a closing comment, let me just thank you again for taking time to walk us through what is really actually a pretty exciting time, in the history when you think about methodology and you think about, tools that are going to be used as commonplace in the next decade. Right now, people are learning about them. I'd say maybe half the people that when I interact with people have said they've heard of the term, they've all heard of the term meta-analysis, and most people still don't know what that is. Network is yet one more complexity above it, but we're seeing how you guys are all thinking about evaluating it in a way that we can, and also changing some of the nomenclature, just the wording. That's new language that I think people are going to have to learn. So, I mean, thank you for leading some of this. I know you're humble in saying that you're a learner, and that's usually the individuals who lead this are continually learning so they can improve it. So, at least on behalf of the individuals I work with, thanks for taking some of that leadership role, Jason. And maybe I'll leave you with the last comment as we close out this very informative session.
Yeah, so thanks again for the opportunity to present, and thanks to everyone who joined this call and raised some good concerns and questions. And I really would highlight this. I hope that if I'm back, a year or two from now talking about a different network meta-analysis, I hope we have further learning. I hope we've optimized the way to present this information. I hope we've made it more approachable. I inherently don't like research that is too complex to communicate. If the research has been done well and if the findings are compelling, it should be straightforward to present it in a way that is intuitive and interpretable. And I think that's the real challenge with these network meta-analyses. I mean, again, to sort of highlight your point, Mo, about the readily available software, people can do these things by pushing buttons without fully understanding the output and what they're doing. To highlight Yuping's comment about the complexity, underneath these, we really have to strive to make sure that this is something that's a value add to clinicians and patients and can help improve the concordance between the evidence and decision making. And if we fail to do that, then it's simply going to be an overly complex piece of work that is not going to have an impact. So I hope that we move towards further clarity, further simplicity, and better ways of conveying the message. And I think if we do that, this is going to be a powerful tool in advancing evidence-based healthcare.
And if all else fails, you can always do a large clinical trial, couldn't you?
those are very hard too. There's nothing simple about large clinical trials.
It's the hammer. It's the hammer, right? Everything's a nail when it's a randomized trial. But anyways, thank you all. Have a wonderful rest of your evening, and we'll hopefully see you on some other of these events. Thanks again, Jason. We'll get you back for some more work as well. Cheers so much.